The Grossman model should provide some theoretical context presented in Chapter 3 in the Burnell text. Now let's take a look at some of the highlights from that chapter. After reading this chapter, you should be able to identify the various measures of health that reflect a wide range of health states, explain how the law of diminishing returns is related to the production of health, evaluate the inputs that play a role in the production of health, discuss the contribution of major government programs to the production of health, and lastly, use the health production function in a graphical form to explain the relationship between health inputs and health status. As noted by Grossman, the production of health is the process of combining inputs to realize a desired health output. And those health inputs can include medical care, lifestyle or behavior, environment, and biological makeup. Burnell notes that for a measure of health to be useful, it should be meaningful, accurate, and representative of a wide range of health states individuals can achieve. At the population or aggregate level, health is typically measured by deaths, births, incidence of chronic disease or prevalence of chronic disease, life expectancy at birth, and infant mortality. However, there are some shortcomings to the population level measures that are commonly used. The first is that they're not suited for analyzing health at the individual level. And the second step is they don't capture information on the quality of life or duration, severity, and consequences of a disease. As we saw earlier when talking about the Grossman model empirically, there are a few subjective measures of health which include self-assessed health status, measures of mobility, and activities of daily living. Another measure that's used in the health and health economics literatures is the Quality Adjusted Life Year, or QALY as they're known. So QALY multiplies the time spent in a health state for a disease by the utility score of that health state, which reflects the desirability of living in a particular health state. Where a year in perfect health has a utility score of 1 and death is equal to 0. So here we've seen this table from the Burnell text that at the utility score of 0.85, years in that particular health state are equivalent to 4 quality adjusted life years, while the utility score is a 1. 4 years in that particular health state would give us 4 quality adjusted life years as well. So you can see how those years in a particular health state are being weighed by the utility score for that particular health state. While this also sounds rather abstract, this is used to influence drug pricing in the U.S. and abroad. For instance, as this diagram from the Wall Street Journal illustrates, the economists have used the QALY to determine the fair price of a drug whenever it's being launched in the market. In this diagram, they show how if you have a 55-year-old with an illness who would be expected to live another 24 years, they know that the health problems would reduce the number of QALYs to less than 24, but a drug would improve the picture. So the remaining lifespan of 24 years, that would be 10 quality adjusted life years without the drug and 15 QALYs with the drug. So this drug would improve the quality of those life years and add 5 QALYs for the patient. They would take those extra QALYs and multiply them by $150,000, which is a predetermined cost effectiveness threshold and is essentially equal to 3 times gross domestic product per capita. And you take those 5 QALYs, multiply them by this predetermined cost of $150,000, and they take that total cost of $750,000 divided by the number of years the drug will be used, which is 24, and then they would suggest the maximum drug price per year should be $31,250. This is just one potential application of the quality threshold for conducting cost-effectiveness analysis, and also for informing what the maximum price of a drug should be per year for patients or their insurance. However, as we will see later in the course, when we talk about cost-effectiveness analysis, the use of QALYs is quite controversial in the U.S. The Patient-Centered Outcomes Research Institute, established under the Affordable Care Act, is prohibited from, and I quote, using a dollars per quality-adjusted life year or similar measure that discounts the value of life because of an individual disability as a threshold to establish what type of healthcare is cost-effective or recommended. So the use of QALYs is prohibited by the government under the ACA. So I think that already illustrates that this is a rather controversial subject. Burnell notes that there's a wide variety of health inputs used to achieve that desired health status, and that includes inputs like medical care, lifestyle, environment, biological makeup, income, education, housing, and government programs. It's also noted that with many of these inputs, as inputs to production are used in higher quantities, their effect on output decreases, and that follows from the law of diminishing returns. Here we have a basic health production function with healthcare on the x-axis and health status on the y-axis. We can see that the health status is also a function of socioeconomic factors, behavioral risk factors, environmental factors, and genetic factors alongside healthcare. The idea shown here graphically is that healthcare improves health status. It has a diminishing marginal product, that is, the change in output. In this case, health status attributed to an additional input to production is falling as we're having more healthcare being utilized. And just as a technical note here, the health production function is a functional form that represents the relationship between inputs to production and outputs. And this functional form will vary by individual. Think about this whenever you're thinking about how many times you should go to the dentist every year. And so if you have oral health status on the y-axis and the number of dental cleanings per year on the x-axis, there's probably some optimal amount of times you would go to the dentist, maybe twice a year. And so in this case, oral health status is a function of diet, regular flossing and brushing, socioeconomic factors, behavioral risk factors like smoking, and environmental factors, including fluoridation of water, genetic factors, and also routine dental cleanings. As you can see here, getting that first dental cleaning per year would have a major impact on oral health status. But going from the 9th to maybe the 10th dental cleaning per year would have only the slightest impact on oral health. So perhaps the optimal times to go to the dentist is once or twice a year. So we're thinking about the inputs to the health production function, and we can think about the following two questions. At the aggregate level, how much does medical care matter for health outcomes relative to other inputs and the health production function? And what led to improvements in health over time as measured by life expectancy at birth, for instance, in now high-income countries? If you think about the spread of infectious disease and the number of deaths from typhoid fever, say here in Philadelphia in the late 1800s and early 1900s, the death rates were incredibly high prior to the filtration and chlorination of water. As you can see in these charts, the comparison of cities, the effect that chlorination and filtration had on the quality of water by city. This was also something that was discussed in much greater depth in a recent book titled Plagues and the Paradox of Progress by Thomas J. Balofsky. But in general, when we're thinking about the factors influencing the production of health over time, in the 1800s, economic development, for instance, improvements in nutrition and standards of living, were perhaps the more important inputs to the health production function in terms of improvement in life expectancy at birth. Overall health status in the late 1800s to, say, 1960, with public health initiatives including the chlorination and filtration of water, improved sanitation, the availability of antibiotics, for instance, were perhaps the more important inputs. And since 1960, the advancements in medicine and medical technology are some of the important inputs at this time. Alongside those public health and healthcare inputs, we also have lifestyle and health, and these include personal behaviors that can influence health, like smoking, alcohol consumption, use of illegal drugs, exercise habits, nutritional choices, sleep patterns, and social capital. In addition to the health impacts of access to clean water and clean air, consider, for instance, the role of the fluoridation of drinking water. A recent paper in the Journal of Political Economy was empirically showing how the fluoridation of water improved dental health, which then influenced productivity, and also led to an income premium because of its impact on appearance. And all of this ultimately influenced the annual incomes for individuals according to this empirical model. There are also biological and genetic determinants of health, including sex, HIV status, and inherited conditions, as examples put forth by Burnell. Income can also play a major role in health. Here's a schematic showing that higher income can lead to greater access to health insurance and healthcare goods and services, which in turn leads to improved health status and productivity, which then also influences higher income. Of course, shock can also lead to the loss of health insurance and limited ability to consume healthcare goods and services, and therefore reduce health status and productivity, which in turn would also lead to lower income. This can work in both positive and negative ways. With regard to education and health, Burnell notes that there are several assumptions about this relationship. The idea that educated individuals may be more knowledgeable about combining different health inputs to produce the best health outcomes. They may be more likely to invest in preventative health measures today to avoid the negative health consequences of the future, and may be more efficient producers of health. And you can see how these assumptions are embedded and follow from the Grossman model put forth in 1972. Burnell notes also that 4 aspects of housing can influence the physical and mental health of a person, including a lack of space, the structural conditions of housing, the location or neighborhood condition, and then also the affordability of housing. It's also noted in Burnell that federal and state government programs can have a direct impact on health production, and these include Medicare, Medicaid, and the Children's Health Insurance Program, or CHIP, TRICARE, the Civilian Health and Medical Program of the VA, and then also the Indian Health Services. You can see from this chart how many people have been covered by these different types of health insurances, according to the most recent data from the Census Bureau. So here ends the highlights of Chapter 3 of the Burnell text.